the Penny Heath from the VCSA, Jonathan, our CEO, the leader of Dorset here, Nick Ireland, Pam O'Shea, Ben Sharland, and Carol, with apologies as well. It is the first time in the room for Catherine Howe. Do you want to say hello, Catherine?
Yes, hello, I'm Catherine Howe. I'm the new-ish Chief Executive here at Dorset Council. So I've been here 3 months. And already there is a ripple effect of my arrival. In a good way, I hope.
Welcome.
Thank you.
And an equally welcome ripple to Aidan as Chief Executive of ICB. Do you want to say a couple of words?
Thank you. So I'm even newer.
You're newer.
A couple of weeks newer than Catherine. So I have attended, I think, a workshop a month or so ago. So Chief Executive of the Council, and great to be here. Thank you.
Brilliant. Thank you. For agenda item 2, the primary care board story, Claire will join us, Claire Metchan from the Dorset GP Alliance. We'll come to that in due course. Online, we have Rhiannon Beaumont-Wood. Welcome, Rhiannon. Siobhan, welcome, Siobhan. And Rachel Pearce from NHS England. I also see, who else is online there? You can help me. Paula, brilliant. Thank you very much. Welcome everybody. We also have some members of the public who are very welcome and observers here today. You're very welcome to our meeting, and thanks very much for coming along. So on to the agenda. We are quorate. Are there any declarations of interest beyond those usually declared that have risen in the last 28 days or since papers? No, thank you very much. The action log from our meeting on the 11th of September, the recommendation is that all items are can be closed. Were there any questions or comments on the action log? We happy with that? Yeah, thank you very much indeed. So we move to the agenda proper, and we're going to start with a primary care story. Forbes, are you introducing?
Just open the curtains and we'll walk around to this. This is Claire. Okay, good morning everybody. Just in time. What we're going to do in the next half an hour or so is we're going to show you a video which gives you a sense of the breadth of services that people that are involved in offering primary care at this point in time. We're then going to focus on one particular service, which has just had an anniversary, and Claire Meachin has just arrived very helpfully. Claire's our lead nurse within the Alliance, but she's also lead nurse at the Adams practice in Poole, and she's clinical lead for this service. So video will take 8 to 10 minutes. Around that time, then Claire's got 2 or 3 slides just to update you on the specific service, and then we can take any questions. So we'll go straight to the video.
Brilliant. Thank you very much indeed.
We can all see it.
Is there sound?
There's sound, yeah.
We turn the sound.
There's good data emerging around improvements in
A bit more.
We're here to tell the world about us.
Hi there.
Brilliant.
I've much appreciated both Dr. Burker and the others who've come to help me when I haven't been able to get out at all, and they've been marvellous and encouraged me. Thank you very much.
When I'm feeling unwell, sometimes I'm not sure if I need to see a doctor or a nurse or a pharmacist. I just know I need help and advice. I think the idea of a family doctor might not be possible nowadays, but instead it's now a family of healthcare professionals, along with advice and tools to help us stay well. It's a whole team of experts working together to help people like you and me.
There's now a real variety of services rather than just seeing a GP and a practice nurse, but there's all these other sort of services that we offer within our network.
still mobile, but she is mostly bedbound.
We are all in each other's rooms constantly. We are one team of healthcare professionals.
Sometimes you might be supported by more than one team member. You might start by seeing a nurse, and then they might suggest you speak to a social prescriber.
I understand that patients often want to see their doctor because they feel that they need to see a doctor, but often we are able to see, diagnose, treat, refer in exactly the same way that a GP would be able to.
We have a toolkit which is very useful in guiding our patients to see the correct person, be it farm refer, MSK, a GP, nurse practitioner, whoever.
A lot of the time it isn't just your sort of clinical needs that you need support with, so you don't necessarily need to see a clinician to get support with that. For example, someone that's struggling with their finances might need support that's affecting their mental health, and my team can help with things like that.
If through an e-consult they had reported some falls that they'd been having, that would come over to the frailty team, who's triaged by myself, make sure that somebody's booked in to go and see them. They'll go and assess what package of care they're getting. If there's a cause caused by medication, it's something that we can look after and we can put right rather than having to wait for a GP appointment.
When we review their medication, we can have that conversation. How are you feeling? What medication are you taking? Is that working for you? Do you like them? Do you prefer something else?
My role is being able to build that relationship with that patient and build that trust and that confidence where the patient can call reception and book an appointment with myself.
More often than not, ourselves as physios are the experts at musculoskeletal.
So one patient who was referred to me was with a restriction in her shoulder range of motion. When the patient came into clinic, I quickly identified that I did not feel that this was a musculoskeletal presentation and actually ordered her a chest x-ray. That, with her weight loss and some blood tests that I organised, actually picked up that she had a lung cancer.
Traditionally, a GP would look at the medical health in the body and how they can solve that with medicine, or how they can solve that with a hospital referral if needs be to somebody else that can look at it with medicine. We are looking at it as what else is impacting on their health.
Our frailty team are all about sort of proactively looking after our patients, and we will go and visit the patients, for example, have a look at their sort of whole social health environment and see what we can do to improve them from there.
Digital tools are also helping people manage long-term conditions from home, like high blood pressure and diabetes, while still staying closely linked to their practice team.
So when we're talking about digital healthcare tools, we're primarily talking about apps that you would see on your smartphone. Within my role, what I'm really looking to do is to improve the patient journey and to ease the burden on the staff working in GP practices. And the introduction of these digital healthcare tools can do both of those things.
If digital healthcare is for you and it does work, there are lots of different ways which we can help you out.
General practice is changing. You might see different team members now, but this means that care is more connected, more supportive, and more focused on you. It's about better care from the right person at the right time.
I'm here today at the GP Alliance event to talk to all the amazing staff that work out in our communities around Dorset and to give them information about how we can add to the services that they provide.
We know that fraud is 41% of all crime, but what's scary is 80% of people don't report. We know reasons: they feel gullible, they feel stupid, they feel isolated, they feel that they're going to lose their independence. The big message we need to get across is they are victims. They have been socially engineered, and we want everybody here to help us get that message across and get people to report in so that we can send them to the right support.
I would encourage everyone to try and engage with their patients for ideas of what they could get involved with to help, not just on the medical side, but the other aspects of life. So we run walking clubs, garden clubs. Our volunteers help us at all our flu clinics, COVID clinics, and of course our leg club, which has been run for 10 years, has proven benefits. Not only for the socialisation there, but also healing rates of lower limb.
My name's Ben. I'm 56 years old and I've lived all my life with a rare skin condition. It means my skin is incredibly fragile. It blisters and tears very easily. When I was younger, it mostly affected my knees, ankles and elbows. But as I've got older, it's spread to my shins and the backs of my legs. The itching can be unbearable, especially at night, and sometimes I would scratch until the skin broke. A little while ago, things got worse. I developed painful ulcers on my legs. They made walking difficult and left me feeling helpless. I remember thinking it was all over for me. Then someone mentioned the local leg club. To be honest, I was nervous about going. I didn't want people to see the state of my legs. But when I finally went, everything changed. The nurses there started me on compression bandaging, and the care I received was wonderful. But it wasn't just the treatment, it was the people, the kindness, the time they gave, and the feeling that I belonged somewhere again. The Leg Club isn't just a clinic, it's a community. Over time, my ulcers completely healed. The pain eased and I could move more freely. I can honestly say the Leg Club has been life-changing for me. The nurses and volunteers are amazing, generous, patient, and full of understanding. I'm now a big supporter of the Leg Club and tell anyone who's unsure about going, please give it a try. It's the best thing I ever did.
We've got some. Thank you for watching that.
Well, thank you.
And I hope you found Ben's story quite emotive, as it is. There is just a few slides we'd just like to talk to you about, just to tell you a bit more about the Leg Club model and how it improves people's lives. And I say I've been running it 10 years now. So the Leg Club model is a registered charity, and they are it's a registered model. But the Leg Club transforms community wound care, and it does that through collaboration, compassion, and connection. The Leg Clubs, they're not owned by healthcare, they are part of the community and they are embedded with the community. However, therefore they really do harness the future 10-year plan. When you're thinking about prevention and community care, the Leg Club actually is there, and it does all of that. It's completely research based. We have there's a lot of evidence around the improvement that it can offer by empowering our patients and becoming very much patient focused. It's proven to be cost effective. So we try to bring together not just practice nurses, district nurses, and all sort of social care aspects. So it can be a one-stop shop. And we've had transport. We get transport to go out and get people who are previously deemed maybe as housebound, but from my feeling, they're not housebound, they're transport bound. So if we can get transport out to them, we can bring them into the Leg Club and into that social model. Next slide, please. So just some evidence around it. So our healing rates are nearly 70% within 1 to 12 weeks, which is way above the national average for lower limb ulceration. There are 4 key aspects to the leg club, and every model is set up the same. So we have an informal open access, so they don't actually make an appointment. They can come within a defined time. So if they needed to, you know, they want to walk their dog first, or they have some other commitment, they can come along at a time that suits them. It also means that we can do proactive care, so they don't have to wait to make an appointment. If they've got a problem with their leg, they can come in and see us straight away. They're always in a non-medical environment, so they're somewhere in the community because they are very much, as I say, part of that community. They're collective. Everyone is treated together. And there might be some people in the room that are thinking, what about confidentiality? I can assure you that everyone there consents to being in that room. And in 10 years, we've not had anyone who doesn't. We had one person, and it was a daughter who chose for her not to sit with everybody else. She came back the second week and she said, I don't want to be segregated. I want to be with everybody else. And they cheer, they support, that peer support is there. And it means they can share their experience, and they actually take ownership of their care rather than it being on the clinician. The other part that I really love about leg clubs is the well leg. It's integrated within the model. So actual fact, when a person has their lower limb healed, we don't stop caring for them. They come back and they see us within the well leg. So we're able to support their ongoing care and prevent people with lower limb ulcerations will re-ulcerate. They are, it is a chronic disease. So unfortunately, they are very likely to re-ulcerate. But if we can support them with the well leg and continue with their care and encourage them to look after themselves and their limbs, we can actually prevent that recurrence. Next slide, please. So basically, it is a really cost-effective model by sort of flipping the coin and actually spending more money, more time on that well leg and keeping them healed. Our reoccurrence rates are way below average. So within the data that we pull from our leg club, we only have 15% reoccurrence in the first 12 weeks and 8% in 2 years. The national average is 70% within 5 years that will reoccur. So as you can see on there, I won't go into all the figures. The actual, I've just come from an up-to-date conference actually, and you know, the country is spending 8.3 billion pounds on wound care. 50% of that is spent on community care, community wound care. So basically, by keeping one of our members in our well leg regime, we can actually save £2,200 per person. Obviously, we have the qualitative side of it as well. So we get people who were previously socially isolated. The satisfaction is huge, and as you heard from Ben's story, it helps re-engage them back into society and part of the community. So it has all that benefits, and we have things like armchair exercise. We have social prescribers that come. We link with secondary care, so we have the vascular team, we have an MDT with a vascular team and the lower limb service, and we have a podiatrist that comes into the leg club as well, so we can look after the whole person. Thank you.
All right, thanks, Claire. So I hope that's given you just a sense of one particular service that sort of ticks all the boxes, doesn't it, in terms of left shift, 10-year plan, prevention, good access, self-help, you know, qualitative markers met, safety, etc. So, and these are the sorts of things we can do. The first part of the presentation was about the breadth of the offer that general practice now gives. So everyone in their head has about, let's go and see the GP, but actually just get a sense of, and that's not everybody, but that's just an example of the numbers of people offering a very, very broad service. And just at the very start, which we slightly missed just because of technical issues, there's the demand for the service. That the evidence at the moment is, when people say, oh, we can't get to see the GP, actually 50%, 50% of the population is being seen every month in general practice in England. And that's staggering, but because of the breadth of the offer. Yeah. So, and that is supported by the figures in Dorset. So with a population of over 800,000, In July, general practice, the breadth of general practice offered over 400,000 appointments. I did the figures in my own practice just to check it was right, and it absolutely stacked up. So we're absolutely consistent. 65% of those consultations are face-to-face and 40% are same day. So when people have a sense they can't get in, just think how many people are getting in. Now, what will then happen is everyone in this room will sit and think, well, I haven't been to the GP for 3 months, so should I go more? What we've got is some people coming an awful lot. So, and some of those people might be the people that are in that leg ulcer club. So anything we can do in that sort of forum to help those people's medical condition, but help their well-being makes a difference. Thank you.
That was brilliant. Thank you very much, Forbes. Thank you very much, Claire. Questions or comments, please? Anyone? That's right.
So it's really, I love hearing models like that, and I don't know how frustrating it must feel to you to know something like that really works, and for this space not to be really good at shifting the cash to where it's needed. And I suppose the thing for me is the kind of like the constant reminder of these community-based social schemes really work. And it's about how do we rewire things so that we make those things work. And I suppose speaking from some of the chief executive, new-ish chief executive Dorset.
Honeymoon.
Yeah, I know. I can say anything at the moment. It's like is that one of the things that we're thinking about a lot is how do we really make third spaces in communities available for this kind of thing, because this kind of stuff just stacks on top of each other. The more activity you get going, the more it creates. And I say it's really a thank you and an observation. As I say, I appreciate you bringing it, because it must be really bloody irritating the fact that it's so obvious that this stuff is great. But I see it and I hear it and I appreciate it. Thank you.
Should we take a couple of comments online, and then you might want to give a response, Siobhan, and then Rhiannon.
Yeah, thank you, Forbes and Claire. It was really good to hear and to watch that, and I'm quite blown away by the leg ulcer, the leg clinic work. Brings me back to my days as a practice nurse. But my query really is, and it's also in the chat around VCS colleagues. We could do a lot to work on how we promote care outside of hospitals together. So I'm really keen to have access to the video, because I think this is quite a key time for us to build public confidence in where they can get care. And actually, I'd love to be showing some of your videos in the hospital setting to really support the sort of shift from out of hospital care. So just really quite a simple ask, but actually it'd be really good for us to work on how we communicate this within the hospital setting.
Thank you very much, Siobhan. Rhiannon.
Yeah, thanks. Obviously, Siobhan and I have got that in common, because many moons ago, it's the same role I had. That was brilliant, Claire and Forbes. From hearing the kind of multidisciplinary approach, and obviously the leg club is amazing and all the impact positively. My question sort of relates to what Siobhan was asking or talking about, and the previous person. We're going to have in that left shift, aren't we, even more kind of, high acuity things moving more into primary care. And it was around the investment into training and development to upskill across all of the multidisciplinary team. I suppose the question is, are we currently doing anything to kind of create that pot that helps with that? I guess there's probably more to do, but it was in that space. But it's really good to hear. Thank you.
Thank you very much. And Dean.
Thank you. It's great to hear things like that. So just wondering, in the services that we really commission and the way that we build our commissioning intentions, kind of got that paper on it, what more could we do, particularly working with the GP Alliance, to link it with the existing services that we've got, or to develop those further, given the great benefits that you're seeing, and that those patients then don't have to go to hospital?
Yeah, thank you very much. Anyone else? Yes, Chris.
Yeah, thank you. I'm the Chief Finance Officer at Dorset Healthcare, and I think from my perspective,
You know, we talk about the left shift a lot, but in reality, this is exactly the kind of example which actually demonstrates how it can be implemented in the community. And as well as that, you know, obviously there's the impact or the positive kind of impact on the acute services that we have. But actually, it felt like there was quite a lot of mental health intervention in what we were talking about from this point of view as well. So actually, you know, more examples like this are great, and I completely agree around the commissioning intentions point around how we can make sure that actually, you know, we're doing more to, I guess, kind of boost the availability and access to this kind of service in the community to actually support not just physical health but also mental health.
Thank you. And Dan?
I'm just really keen to understand how like the leg club was spotted, who did the analysis, who kind of got the initiative going, and then if there's a future pipeline of what the next leg club is. I'm not going to say like whatever it might be. Have you got those sort of pre-baked? And it should be good to get a bit of information on that, please.
And Aidan.
Thanks. So I'm from Bournemouth Christchurch Pool Council. So first of all, it's that moment of, this is what left shift means.
Yeah.
So it really brought it to life. So thank you. I'm interested in sort of one of the final lines of, or one of the points, people come as members, not as patients. So I'd be really welcome a quick comment on what does that mean or feel like? Is there something here about sort of people taking more responsibility for their own kind of healthcare, health and well-being? And that's a really interesting bit for me. So I'd welcome a quick comment.
Thanks very much. So it gives you the chance to come back. It's interesting, isn't it? Many of the questions are the same theme in a way, which is this is really, really good work, but how do we make sure that this is happening by design rather than by huge individual effort and almost happen chance? And Dean mentioned the commissioning intent paper later, and as an ICB, we have to think about, so how do we use contracts and funding and shift resources into prevention, and how will that actually happen? Because we do genuinely want to see radical change over the 10-year plan. So in a way, the questions from nearly everybody are, how do we do this on an industrial scale and encourage it? And how does the ICB frame contracts in a way that there's more of this? Over to you.
Yeah, so you start.
Yeah, okay. So I'll try and capture as much as I can. So I'll first touch on about the background of the Leg Club, and please, if I do talk on, please let me know, because I'm very passionate about this.
You have a very willing audience. Go on all you want.
So the Leg Club is not my idea. The best foot forward was my baby, but the Leg Club model was set up by a district nurse about 25 years ago in another part of the country, and the time that she was taking to go out and see everybody, and finding that a lot of those people were very isolated, they were very lonely. And actual fact, as I've stressed as well, I think we deem too many people as housebound. They're not housebound, they're transport bound. They can get out if they have access to support to get out of the house. So she managed to encourage them to come out and come into a central point. And then the benefits started to come, because you get that peer support and that reconnection with the local community. And on board, you get the volunteers that come along to support that. And so that was the model that was grown and developed. And from just in a very brief, from my background, I do work for the Adam practice, very large practice. We were inundated about 11 years ago with people with lower limb, and I audited it. It was taking 50% of our nurses' workload, and we were struggling to do everything else that we needed to do. And I just thought there's got to be a different way to do this. And we looked at various things, and we came upon the Leg Club model. And I went to see one, and I was just like, wow, this is, myself and a GP went, and we just went, this is what we need to do. And I would tell you that and within a year, the cost savings within practice were the equivalent of 2 full-time nurses, because of our healing rates improved so much by having the Leg Club model. We were then able to then invest that into supporting other areas of care. So it actually within a year, it had the cost savings. So your comment about members, yes, they're members because it's a non-medical environment. So we call them members so that it is their leg club. And I always say it's the volunteers and the members that run that leg club. As clinicians, we are there doing exactly the same work that we do within our practice, within our clinics. It's the environment that makes the difference. And it's that does the magic, and it's getting people back engaged with the community and getting them out. We know that social isolation, if you are 15% more likely to unfortunately die if you're socially isolated. So actually about getting people out, getting them engaged, and absolutely, as you said, sorry, I can't remember your name, but it encourages them to take back care, take back responsibility for their care instead of waiting for the clinician to tell them what to do, because they talk to the next person who's got lived experience. I haven't lived with a lower limb ulcer. I don't know what it's like. I have the training, I have the skill, but I don't know what it's like to live it. The person next door who's having the same treatment knows, and they will applaud each other when someone heals. You know, it's like ringing the bell on the chemotherapy unit. It's exactly the same environment. They know each other's birthdays. You know, we do, and the volunteers provide all of that social interaction. So we have parties, they've done boat trips around the harbour, gone to garden centres. It gives them their life back. And that to me is what really is important. Instead of treating people as a patient, we're treating them as a person and a holistic person. So that's sort of the ethos of leg clubs. Leg clubs can be set up anywhere. You just need the resources to do it. And literally, as you said, it's about working with the community about what environment, because these are chronic wounds. They don't need to be in a clinic environment. They're chronic wounds. They're very different. It's having, if it's in that community, it brings people together. So the other thing was training. There was comments about training. I'm very passionate. I've been doing some of the work around the integrated nursing, and actual fact, I think particularly nursing, we need to have a joint skill set so that nurses, whether you're in secondary care or in the community, we can all look after the same people. We have a joint skill set. So, but it's making sure that people have the opportunity to have that training and keep and maintain their update and their skills.
Forbes.
Okay, thank you. So mental health, well, you know, it goes hand in glove, doesn't it, in terms of people's well-being, and as you know, that we see just a large amount of mental health from the very young to the very old in general practice. But the message is the majority of mental health, the vast majority of mental health, can be safely and effectively managed in the community with the right support, the right access to the right support, and where services are concerned, I would say appropriate integration and connection of services. So you'll have your secondary care mental health issues, which can't leave secondary care for a very good reason. But the majority of the remainder, I think the other thing that's really important is early intervention. So if you can intervene early, and this is about access to services in the community, you significantly reduce the morbidity and actually significantly improve the long-term well-being and outcomes for an individual. So we have to have mental health working as closely as it possibly can do, I would say, with general practice. Commissioning intentions, absolutely. What we've got to watch here in the NHS, because we've done it before, is talk prevention, yeah. And suddenly we're under pressure to deliver intervention. 4-hour wait, 18 weeks, and that's what can come to this board as a year end with the political cycle. I would say we've got the strongest message we've probably ever had to try and deliver on the aspiration of prevention. And I think we've got to give it a good go. Having said that, the environment is very difficult, and we've just got to acknowledge that. I think the commissioning intentions as described are very good. What we then need to have is a delivery plan that matches the commissioning intentions and is delivered. It doesn't then lose traction. So commissioning intentions that we have later on have many good things in it. The workforce plan, the delivery plan, and of course the finance plan has to then match that. And it's not all about the money. These services are cost effective. We know that as a whole,
care delivered at home or close to home is the most cost effective and best outcome measure that the population can have. So that has got to be what we aspire to deliver. And that's not to denude the acute organisations of support for their services, but we've got to create this gradual shift. That's what the 10-year plan, in my views, are.
And we ought to sort of capture and park those comments for the commissioning intent discussion later on. Paul.
So I'm optimistic because I think if we go back over the last many years, we've taken an approach where things go really well when you've got a zealot behind it who's going to drive it at the front line and make it happen. And it is very much individual dependent. So many things when that person leaves, the thing fold because nothing has been established. Or we've had pilotitis, where so many pilots happen that then run out of steam or don't get adopted. And so you get tiny pockets of excellence without necessarily driving the whole population to better care. I think our opportunity around shaping our approach to neighbourhood health is a real, is a different way of looking at it, but I think will do two things. It will allow local creativity and freedom to create and use the totality of your assets in a neighbourhood in a creative way, such as leg clubs or the next club or whatever it might be. It also allows us to make sure that we capture the learning and we see where there are better outcomes happening for interventions, set the expectations that those outcomes are delivered across the whole of our population. So I think the way that that is structured, the national direction that's coming around that, and the way that we're getting our neighbourhoods working together within that programme gives me optimism that we won't be able to manage both of those, that we won't have so much central control that we dampen down local creativity, but we'll have a way for local creativity to drive benefit for the whole population.
Yeah. Yeah. Any other, Claire?
Could I make just one more comment? I think talking about the commissioning, up until now, and I'm talking lower limb, the commissioning has been on activity. So as a GP practice, I am probably actually losing my practice money because at the moment it's funded per every time we see a person with lower limb, to do their dressings. For me, the real difference comes with it being outcome based. So, and I have been working with the ICB on the new lower limb pathway, that actually about what we should be doing is supporting the maintenance of that person to prevent them getting another, which we know, because when they ulcerate, is going to cost us lots of money and lots of time and all of the impact on the services. Actually, fact, if we can look at it being outcome, how can we maintain that person from the healing? So treating it like a chronic condition, like we do with our COPD patients. They all have an annual review, and that's how we're paid through the service. Lower limb, it's not the same at the moment. It's being done, and as I say, I know I've been working with the ICB on that to be outcome based, to actually get people to the point that they're healed and be able to be funded to support them staying healed. And that's where the leg clubs come in that well leg, being able to support them in that period of time. So we reduce the time it is till their next reoccurrence, very similar to what we do with all our other healthcare.
Yeah,
so I'd just like to make that comment.
I don't know the answer to this. I'm hoping you do, Alison, because somehow, when I'm always impressed when I visit lots of GP practices and there are multidisciplinary team meetings with social prescribers, and you see the GP practice sort of at the hub of pulling together these opportunities. And somehow, Alison, we need a funding system that funds that at a time when a lot of the national noise is maybe going back towards tariff or something. But as an ICB, we want more of this. And so what's the bit of magic we can work, Alison, in order that we deliver this?
Magic might have to come later. But yeah, I think we're at a point where there's absolute recognition that our funding arrangements, our contractual arrangements need to change as we go forward to support this. And we're in a great point within Dorset. Actually, if we think of some of the things we're doing, the integrated neighbourhood teams, presentation we've just had, it's humbling in terms of all the different jigsaw pieces that are going on within Dorset and being ahead of the curve. I think there's a question for us as a board as we go through our evolution about how we develop some of these, and picking up the work you're already doing on the Legos, what does that look like in terms of the contractual arrangements, the outcomes focus going forward? And picking up Paul's point just now, isn't it? How do we get our neighbourhood health model so we can start to define the outcomes at place and neighbourhood that we want to see going forward, and then bring in the partners, you know, to deliver that across primary care, across community services, mental health, you know, bringing the acute. What does that look like, you know, with the, you know, the backbone with the voluntary sector that fits underneath these as well? How do we create that framework that's going to be appetising and exciting as we go forward? And we need a complete contractual shift to do that, and we are working and having those national conversations on what that's going to look like. We're still going to end up with PBR for acute sector, and we're moving back into that position, but actually we need to understand the treatment versus the prevention and get back to more of a balance that we probably lost over the last few years. So definitely we'll be picking your brains in terms of some of those ideas that we need to bring into those national discussions to influence this as we go forward.
Yeah, well said.
Just a thought, and this is not well thought through or anything yet, but I can see kind of with this and a suite of other kind of prevention issues that you sweep that up into one package, and then you look at the balance that's being driven within that, so that where you get a kind of potentially a fund to actually make sure that you're targeting the ones that you need to, and the maintenance of others, and you keep an eye on a range of indicators that you've got of what is kind of good practice, kind of not having to refer or not having to treat, but you've got a range of money there, so you can direct it in the way that you've got, and you focus on the things that are bubbling up kind of in different areas. So just
thank you.
The thought there.
Thank you. And Catherine, final word.
So going back to immense positivity, one of the things that we're thinking about is how we get away from commissioning services into community spaces, but not actually fundamentally supporting that thriving community and its infrastructure itself. So I think there's a collective piece of work here, which is that actually if we see that this left shift is the model we want, acknowledging that a community is a community, that we're all working around it, and that what we need to do is have a collective responsibility as to how do we help it thrive. And I think there's something very subtle in the way that we fund infrastructure. We work with the VCS as a whole that will enable us to strengthen the resilience of those underpinning community spaces, which allows this stuff to just grow and grow, which if we commission service by service, we cause enormous amount of anxiety and fragility in that underlying system. So I think it's paying attention to that infrastructure is really important.
Thank you. Thank you very much. So, look, thank you on two counts. One, it's a really interesting patient story, and Claire, please pass back to everybody involved in the Leg Club our congratulations and thanks for the work that's being done. But thank you, Claire and Forbes, because as you can see, we want to be a successful new ICB that helps leftward shift and prevention and neighbourhood health. And a patient story like this helps us think through what are some of the issues that we're going to have to grapple with. And in fact, we'll segue nicely later on into our first discussion on commissioning intention. So thank you very much indeed. Brilliant. So I have a very brief chair's update, and then I'll hand over to David to give a chief exec's update on behalf of Jonathan. Obviously, the big picture at the moment in public services is waiting for the budget on the 26th of November, where clearly the Chancellor will have some difficult decisions to make on public spending balanced with how our resources driven, and for all public services that probably means that we have to keep a tight grip on the money whilst trying to pump prime transformation. That's certainly true for the NHS, and of course it's true for local government, where you see some quite major pressures like SEND being deferred in terms of possible reform of those areas. And so I think for all public service partners around the table, we're in the position where the budget really matters, but it's unlikely to offer solutions, and we're going to have to find a way of transforming public services and managing demand against a very difficult fiscal backdrop. Obviously, a lot of my attention is on the formation of the cluster. All 3 boards are operating well, and thanks to Kay as vice chair, but here at Dorset, and we are essentially on target for the operating plan and our finances. I don't say that lightly, Alison, and there's a huge amount of work going on, but the show is on the road, and obviously we want to make sure that we hand over to the new cluster arrangements from the 1st of April. In that regard, I've had a lot of meetings with MPs and with key stakeholders, not least local authorities and GPs. 2 things just to say. You would have seen in the news the day before yesterday that the Treasury has given authority for the voluntary redundancy scheme to proceed. We've discussed that a great deal at previous board meetings. And in a way, I think it's good to see movement, but I think we ought to say to you, David, and all staff, you know, it probably comes as a bit of a shock as well, that it looked like restructure was being deferred, and now it's coming forward again. And so it is a double-edged sword, and please pass on to managers and staff the board's thanks for the hard work that's taking place against that difficult backdrop. And finally, the Secretary of State yesterday at NHS Providers event in Manchester started to lay out some of the government's thinking on the next steps of reform, including of the acute sector. 8 pilots announced for advanced foundation trust status. And I think it's public, isn't it? It is. Okay. Yeah. I'm not giving the game away, Chris, but you might want to say a couple of words, Chris, about Dorset Healthcare being one of those 8.
Yeah, really happy to. Thank you. So yeah, this is so NHS providers in Manchester in the last couple of days. As we know, there's a conversation around in the future developing a new wave of foundation trusts, or advanced foundation trusts, as you say, and then kind of a pathway towards the potential recommissioning of services locally through IHOs, so integrated health organisations. And I think it's particularly relevant based on the conversation we had today, isn't it, around the potential new mechanisms of funding communities and looking at integrated neighbourhood health from that point of view. So the announcement, which I'm not, as you said, I'm not entirely sure whether it is public knowledge or not, but like I said, it's in the HSJ, so it's as public as it's going to be, right? So Dorset Healthcare has been selected as one of the 8 trusts nationally to be able to apply effectively for advanced foundation trust status, which I think is obviously incredibly positive news. There's going to be a significant amount of work in the short term as to actually, 1, what it looks like, and 2, what the pathway suggests. However, the anticipation is there's a degree of kind of earned autonomy in terms of how we operate the finances, commissioning flows, and other things within the system as well, which is great. Obviously, whilst Dorset Healthcare is kind of the named trust in this, this is a significant piece of partnership work more broadly across Dorset. So working, of course, with Dorset County Hospital, UHD, local authorities, primary care, etc., as to, you know, what this looks like as well. But it's very promising news. I think it demonstrates a lot of the areas of focus and the path that we've been treading within the Dorset system to be able to kind of progress towards this. But we kind of await more information as to what it looks like. But it sounds very positive.
Rachel, online, obviously good for the Southwest that one of the pilots is one of our trusts, and you know, please be assured we're really keen to make sure that local authorities, GPs, the trust, the IHO itself, this is an opportunity for us to shape how partnership can create proper neighbourhood health. I don't know if you wanted to comment on that, Rachel.
No, it's really welcome. I think
as you rightly say, it's an opportunity, isn't it, to really shape, and we're still influencing national policy as well. So I think that's important in terms of very, very proactively feeding back. There will be further tranches, so let's hope to see more organisations, including those in Dorset, in the kind of next stages as well.
Thank you very much indeed. So I'm happy to take any questions if there are any for me. I don't see any hands up, so we'll move over to David.
Well, can I just ask quickly?
Oh,
please?
sorry.
Yeah, thank you. First, just on that specific topic, I think it is in the public domain. You can certainly access it on the web. So, I'll take that as in the public domain. First and foremost, this is a good news story, isn't it?
Yeah.
Congratulations to these getting onto that step. I suppose what would be helpful to have is just, and maybe can't have it now, and I know I'll be speaking to Matthew, is so how can we support you to actually get over the line? And secondly, how can we maximise the potential opportunities that this might bring to Dorset as a system?
Yeah, and
there's no point in Dorset Healthcare looking great, and I could have a list of things that Dorset Healthcare is doing very well for Dorset Healthcare, but not helping me very much.
Exactly.
That's the bit we've got to
and
this to. Let's see how can we help the whole population.
This being a system asset, sorry, Forbes, I spoke across you. This being a system asset, and Matthew and I have discussed the commissioning strategic intent of what we want to achieve through neighbourhoods drives all contracts, whether that's an integrated health organisation contract or a different neighbourhood contract. And so I think we're all really keen, Forbes, that this is not an organisational form that, welcome as it is to get. Actually, this is a system solution that everybody helps to design.
Thank you. Yeah, and as I say, obviously it's positive news in terms of Dorset Healthcare being named, but to me, in the way that Matthew's articulated, certainly within the organisation over the past 24 hours, let's be honest, right, it's very much a partnership piece of working. So like I say, the interaction across the whole kind of health economy is going to be really key to do this. It does feel Dorset Healthcare being community mental health across the entirety of Dorset actually gives a really good opportunity, I guess, for kind of everybody in the room and the respective organisations as to how we can shape that kind of differently going forward. And like I say, linking back to the primary care presentation this morning, that's a prime example about how we can look at doing things in a different way. And I think this gives us, without knowing loads of information, it feels certainly like it potentially gives us the opportunity to step towards that.
Yeah. But where will these neighbourhood health hubs be? What sort of services will they have? How do we problem solve with local government and other agencies? We sort of want all that on the table, don't we? Okay, thank you very much. And I'm sorry to have spoken across you there, Forbes. David.
Thank you. Just blown my script out of the water then. No, I'm joking.
West Ham have won 2 in a row. Do you want to cover that? It's good news.
So thank you, colleagues. I'm covering this today as Jonathan's in London meeting with Sir Jim Mackey and team about services elsewhere in our ICB cluster. I was going to point out actually, and it's fairly self-evident now from the conversations we've been having, it's been a really, really busy period since the last report to the board with a number of major national, regional and local developments. And some of those, a number of those are outlined in the paper, and I'm not going to go through them all in detail because it would take too long, but I want to draw your eye to a handful of things because I think they're important to amplify. First up would be the medium-term planning framework, which is referenced in 2.3 and 2.10. And it marks the beginning of a significant shift towards the new policy direction because it's seeking to gear our organisations and our system towards the delivery of finances and performance now and towards those new models of delivery, those new contracts. So it's really laying the framework and the groundwork for that. And the announcement we've just been talking about, which was on my list to flag, is really, really important. And it's great for Dorset that we've got the opportunity to be influencing that. And I know from the conversations and the work we've done over the last 2-3 years in Dorset, that Dorset Healthcare will absolutely bring that to the table as an opportunity for the system, for all our partners in the system. So we need to squeeze every ounce of opportunity out of that we can. So we're moving at pace in the development of the medium-term plans. Our returns for that are required by the 18th of December, with final versions due early in the new year. So there's a huge amount of work underway at the moment to try and pull those plans together, and they need to be completed at organisational level and at system level as well on this occasion. Keeping going then, so the publication of the strategic commissioning framework set out in 2.4 is, whilst it's intended primarily to support the development of the new model of ICBs, it also has significant implications and opportunities for provider, primary care, local authority and PCSE partners. I think it gives us the kind of framework that we need to do the things that we've been trying to do over the last few years, and makes it focal point of what the ICBs are about. That's really exciting. So really looking forward to working with our colleagues on that. Really important, I think, just try and jump to 2.6 because I don't want to miss this. When I did my first draft, I didn't really sort of pull out this particular item, but I think it is really important. And I love the way it's phrased in here, really. So we need to, I want to, all of us to underscore our collective commitment to the national NHS commitment to fostering inclusive, respectful and professional environment for all our colleagues, and in fact, anybody who comes into contact with NHS services. As it says in 2.6, we want to assure our communities that we are unwavering in our commitment to tackling hatred in all its forms. And I thought it's really important to land on that one, because we can get embroiled in the big changes and the work that we need to do, and the planning and the resident doctors' work, but I don't want to miss that one. I'm talking of the resident doctors' industrial action. So from tomorrow, that's the 14th, a 5-day resident doctor strike begins, which will last until the 19th of November. All partners have worked together to mitigate the impact and protect service delivery as much as possible. And again, an important message to our colleagues here and to anybody who might be viewing this online today. It's really important to remind patients that they should continue to attend appointments unless told otherwise during the strike period, and should also continue to access services in the normal way if they need urgent or emergency help. We're just managing the implications and the impact of the strike, but there's no change to services overall. On a more big note, there are kind of 3 things I wanted to finish on. The first being that the Dorset Health Partners had a very constructive meeting with South West Regional colleagues as part of our mid-year assurance review. We got some really strong challenge, but strong support as well for the work we're doing to deliver our operational and financial targets. And we're really grateful for the input and the shaping that NHS England have provided us with that in helping us get to some really strong plans. There's lots of work needed now to deliver on those plans, but it's a really important milestone in our commitment and our journey to delivering that. We've already spoke about neighbourhood health. It's really exciting actually to note and recognise that Dorset Place Partners have been successful in a bid to be part of the first wave in the National Health Neighbourhood Health Implementation Programme. Being part of this programme will help accelerate our local improvements and bring benefits of shared learning and insights to in fact the whole of Dorset. When we were invited to put applications forward, we put one forward as Bournemouth, Christchurch and Poole BCP area application, and one as Dorset Council area application. And we made a commitment in doing that, and whichever one, if any of them were successful, we would share the learning across the whole of Dorset. And we have been successful in one of them, and we are doing just that, and it's really, really exciting. And as Paul alluded to, this is our engine room for that creativity and energy of different ways of working and embracing local ideas and initiatives that can really make a difference to people's lives. And finally, just to draw your eyes again to the progress and achievements highlighted in the appendices from ICS partners, there's clearly a huge amount going on, and it's really positive to see the progress and positive impact that those developments that are reported there are having. It kind of warms the heart, isn't it, to see people trying so hard and working so hard and making such good progress. And when there's so much else going on, we are continuing to make a big difference to people and the residents of Dorset BCP area. So it's great to see that, and it's important to note. That's all I was going to say, Chair, for the moment. Happy to take questions.
Thank you very much. Any Any questions or comments on David's report? Please, anyone online? No? Okay.
Oh, I was just going to say, I was going to save my questions for, because there's two items, aren't there? One on strategic commissioning and one on the new planning framework, actually later on in the agenda. So I was going to wait till then.
Okay, thank you very much.
It was just a super quick point about, I'm really glad you highlighted the point about racism and anti-Semitism. Our staff are experiencing the same in increased amounts. And I think that's a really good space for us to be working in partnership. Yeah, so let's talk about it.
Yeah, thank you very much. Really important. Okay, thank you very much, David. So we move on to item 5, the board assurance framework. David, we're still with you.
I've still got the mic. So thank you. So this is the updated board assurance framework. As we've reported in all our recent meetings, we've agreed to stop the overhaul of the local board assurance framework, the one for Dorset, and transfer that work to the new cluster ICB. So it'll be part of its governance developments as it comes into readiness for operations from the 1st of April 2026. But in the meantime, we have agreed to maintain our local assurance framework and its monthly review. It continues and it is reported into our subcommittees. So what you've got here is the latest changes and developments and updates. These are outlined in sections 2.4 and 2.5, and I'm sure we as exec leads can answer any specific questions that people might have. But at this stage, because it's already been through the subcommittees, we're asking the board to note and approve the assurance framework.
And what's your big picture, David? We've seen the papers, but obviously the BAF has an important role to draw together all the other risks that we're looking at and look at the big picture of, are we on target to achieve our objectives? So in informing the BAF and having the discussions, what are the key couple of tensions for you that the board should think about?
I don't know about tensions. I mean, clearly our operational performance and our financial performance are rate limiters in their own right. So they take a lot of focus and attention to get them on track and to keep them on track. I think what is important and, dare I say, impressive, that's my judgment, is that we're maintaining focus and energy in some of these other key areas, and some of which we've talked about today in terms of the local developments of services, the neighbourhood health pilots, and so on and so forth, to try and keep that side of our work going, because we know if we can achieve progress in those big strategic areas, then we will ultimately support that financial delivery and performance sustainability achievement so far.
Yeah, thank you very much. Rachel.
Thank you, Chair. We had a very good discussion about digital maturity, didn't we, and cybersecurity, etc., at the last board. But just in reviewing the board papers, there's some contradiction around whether digital maturity is intolerance or out. So I mean, and I can provide the team. So looking at the various pages, sometimes it's in, sometimes it's out. Can we just be clear where it is? Thanks.
Yeah.
Cool. So digital maturity is out of tolerance at the moment, but subject to the digital strategy, which is near completion and going to partner organisations, governance committees and boards within the next cycle. Subject to that being signed off, we envisage us moving into within tolerance once that strategy across our system is approved.
And we've got a discussion later on.
Cybersecurity, we've got to focus on cybersecurity in the second part.
In part 2.
In our board.
So we can regroup and check that, Rachel, if that's okay.
Yeah, thank you. Thank you.
After part 2. Yes.
Just commenting on the BAF, if that's okay. So it's not really a question, just to build, I think, David, on what you said. It is currently written down, it's clearly against a set of strategic objectives before the ICBs were redefined for the future. And I think it's a known job of work. We're going to have to reset the BAF once we kind of get into kind of established cluster. I continue to be assured that for managing the day-to-day strategic things which will endure, the BAF continues to be relevant and there are good actions in there. There is a big strategic risk, though, that we just drop the ball in transition, and that's not really captured explicitly in the BAF. But it is captured in a risk register, which is being oversighted at the transition committee for the cluster, which is accountable back to this board. it might just be a thought, David, to see if we can either as an addendum or as a cross-reference, just recognise that that's out there as a strategic risk. It is under management.
Want to comment?
Well, no, I think it's a great suggestion. I'll take it away.
I think it'd be quite hard as well, Adrian, and that something that strikes me as cluster chair is that there are some things that are clearly a risk across all three systems, dentistry, for example. On the other hand, you can see some individual items in one system that are quite a risk and need discussion, but they're not in the other two. Lobotomy is, on the whole, I think, fantastic in Dorset. I had a blood test the other day. I got the result text to me that afternoon via my GP. There's another part of our cluster where GPs are waiting 12 weeks for blood tests. And so how are we going to make sure, David, that in our cluster-wide BAF, we don't ignore some very significant risks that might not be cluster-wide?
Yeah, well, that's the work you'll have to do.
Yeah.
Part of the board assurance framework. So the board assurance framework is obviously around our strategic objectives and our strategic plans, within which will be these building blocks that we need to address, and whatever high standard we aspire to will be the standard we have to bring all parts of the geography up to.
Yeah.
So that means at locality level as well as
exactly
at
exactly.
ICB level.
Yeah, Dan.
Just a question on timelines, really, because we're in this holding, not maintaining the back, and I don't mean that's a geography threat. I mean it's a sensible thing to do. When do you think that shifts? Or do you not have a sense of that yet?
I don't have a sense of that yet. I mean, certainly, well, we'll come to it because we've got a transition programme update, and there's been some developments outside the paper, one of which is the target operating model and the move to the outlined strategy, vision, purpose in lieu of the full development of the strategy. Once we get into that place, then you're starting to then build the governance around it, which then gives you the BAF. So that will be the final quarter of the year going into the start of April 26.
Yeah, well, you're not like an action, but it's just this. I don't think the board would want the current stance not to be time limited. I think we're saying it is. We just don't know when that limit is.
You need to know when that is. Yeah. And I don't think we quite know that yet, but you are working on it. Yeah. Anyone else? Okay, we approved the strategic risks as given in the BAF. We'll move to our break. 10 minutes, please. Thank you. Well done. We're on to item 6, the committee escalation reports. We're starting with FPC. Adrian.
Yes, thank you. Yeah, so for those that are new to our board, we restructured the committees probably 2-3 months ago. Finance committee is one of those that moved to a monthly cadence because we wanted as a board to have additional oversight on execution against 25/6 and planning for 26/7. So you've got 3 updates since previous ICB board. I guess things to pull out, when you go to the finance update later on in our papers and the performance pack, we're largely reporting there or thereabouts at month 6. The forecasts, though, are starting to signal a significant variation for year end versus the plan. And in discussion with region, it was agreed that we would move to a recovery plan situation. And I agreed with Alison that it was appropriate for the finance committee to meet exceptionally on the 29th of September so that we could understand the recovery plan, challenge it and get comfortable that it was an appropriate system plan to put in, working with providers. And Siobhan Pete was there for you, Chris, you were there for Matthew, and we worked through in sort of line item detail. And got comfortable. So we approved support for that recovery plan at a system level. There were still some details to follow at that point. And we then, at the subsequent meetings of the finance committee, worked through in more detail to get comfort. I think where we stand, and the important point for board to just be updated on today, is that we are now working to a recovery plan, to contract recovery plan with our providers, and we've agreed that we will on a monthly basis now start to look at trajectories against the recovery plan alongside trajectories against the plan, because we are expecting there to be some variance around that. It may be that Alison, in the update on the performance pack later, will spend some more time on those variations. Some of the particular items that we spent some time kicking the tyres around included the expected over plan spend on independent sector providers, where we've got a number of challenges in terms of levers to control volumes versus rate. Dean's talked about that previously, but we had a couple of goes at that, and I think we were assured that the right actions were being taken, but there remains a risk to the overall delivery of the plan coming from that. And then we had a number of what I would call more routine updates in terms of readiness for medium-term plan, and also some contracts that are going out to tender around, for example, unplanned non-emergency patient transport, which has got a long and checkered history, and we were just going through making sure that we were putting our best foot forward to have learned the lessons from the past there, but also particularly to make sure that it's not just a finance mindset as we go through the procurement, because we actually know that patient experience has been up and down in terms of the services that have been procured previously. So we were pleased to understand the approach the team were taking with that. So I think those are the key points.
Thank you very much. Alison, did you want to add anything?
You did a very good job in terms of where we are. I think we've shifted our focus now from the recovery plan to delivery for this year, because we need to make sure we deliver the financial position alongside everything else. So that's the focus, and we'll keep on taking that with the finance committee to ensure everybody's briefed and we've got that assurance collectively between us. And it's great now that we've got Pete and Chris has joined our finance committee as well as the non-exec directors of our trust. So it's a really good and balanced conversation.
Chris. Yeah, thank you. Yeah, it's a really good summary, I think, where we are, and absolutely recognise that in the providers as well. I think the two kind of points I would add are, firstly, even before the recovery plan, we have a very stretching and there's a large degree of risk within our underlying efficiency programs. So while obviously the focus on half two delivery is absolutely critical, and we're committed in line with what we discussed in the committee, actually those controls and focus on our kind of baseline cost improvement as well. And then the second element, kind of building, and we'll pick this up, I'm sure, through the medium term plan work, is that focus on recurrent as well. So inherently, a lot of our half-two recovery plan does have a large degree of non-recurrent element as well, which won't support going into next year. And so wherever we can make those kind of underlying and recurrent savings, that will only support us going into the future year, because what we don't want to end up in a position is we deliver this year by hook or by crook and leave ourselves in a really detrimental position going into April.
Yeah, I think we discussed here before, didn't we, the worry on workforce, that we were seeing a reduction in agency, but actually there was more bank, and we weren't seeing workforce reductions recurrently. Are you assured on that now, Adrian, that we'll go into next year in better shape, or is that still a risk?
So, well, no, so it's still a risk, I would say. I mean, the discussions at Finance Committee included a review of workforce trajectories, and the recovery plan numbers and glide path for WTE are different to the plan glide path, which is a reflection in part of some of those things that, Chris, you're just calling to attention about the delivery of the underlying recurrent savings. We do have a revised glide path, which we will check against on a monthly basis, so that the board can be informed in terms of trajectory. But it's all to deliver broadly, I think.
What are your thoughts, Alison and Chris? I mean, do we watch, or do we ask for anything else? The risk is it's going to be a difficult winter. Jim Mackey has made clear that the money next year is going to be very tight. There'll be less deficit support. You know, so should we regroup on this again if we've got any risk that we take too much cost into next year that we should be dealing with this year?
So I feel like doing my finance update for later, so that's great.
Well, it's just because this is the high level.
No, it's fine. That's great.
Discussion. So it's
probably got conversations going on together. So I think, Rob, you were talking about temporary staffing.
Yeah.
And I think, you know, there are some really good green shoots going on with that. You mentioned the agency had reduced a lot. We did see bank had gone up, but actually that's coming back down. So all our agency requirements are coming back in control, and we can see some really strong workforce controls in terms of the way that our providers are supporting us on that one. So I think, you know, we are seeing the green shoots. What we then had when we signed off the plans at the beginning of this year was a really stretching workforce target. As part of our H2 plans, we've revised those workforce trajectories with our chief people officers across the patch, and bringing in much stronger controls around the rest of this year. Where that does leave us is that doesn't deliver the original workforce plans that we set out at the beginning of this year, but we believe the rest of this year it's more deliverable, and that's the bit we will continue to keep track of as we go through. What that does mean is we are more reliant on non-recurrent.
Which is what Chris said.
Which is what Chris said. So, and now that's come out in terms of the BAF as well, which is why the finance one is still outside tolerance. What that means is we go into next year with more of a stretching financial target than we'd imagined at the beginning of this year. And now we'll come into next year's planning round. So as we go through the planning updates, through the finance committee, through the board, as we go through the next couple of months, that will be something we'll be bringing back on a regular basis around what that looks like. It links in with a lot of the conversations we've just had. So in terms of how do we start to change our system going forward, but also then in terms of the clinical strategy review that we are now looking at, how do we look at remaining within the affordable cost base, and how do we start to change our services? So picking up everything we talked about this morning, the neighbourhood plans, now the announcement around the IHO, how do we move towards that at pace within Dorset to get to that sustainable footprint? So we will continue to bring that back to, you know, say the board and through the finance committee through those updates.
Thank you very much. And the importance of these revised trajectories being met and not further slipping is really important, isn't it? I've got Siobhan and then Dan.
Yeah, just to probably just reassure that we absolutely have a much stronger grip of all our workforce numbers this year than we've ever had before. And I think that's across all the providers in Dorset. And we've put in additional controls within our organisations. But I suppose, Chair, I'd say we need to really start focusing on planning for next year. So keep a grip and deliver this year. And I know that's your point. And to actually achieve a sort of much better run rate into next year, but actually focus our time on planning, because we've really got to sort out next year. The bit that I just need to flag are two things. One is industrial action will adversely impact. And that is the reality. And at the moment, you know, it starts tomorrow for 5 days. And then there's highly likely potentially to be an additional round just before Christmas. And that does have an impact in providers in the rhythm of how we're working. And then the second point is next year, we have to land the reconfiguration safely. So just, it is a tough time. We will do absolutely everything to bring our numbers in. And I'm meeting Simon Fuller, I think, possibly later today. Any help that we can have, I will absolutely accept. And also just to add, NHSC did a deep dive on our CIP programme across UHD, and Jeff Buggle told me it was a positive report. So I am going to take that.
Yeah, I would definitely take that. Dan and then Catherine.
Mine's just for comprehension, and I nearly asked it in the Chief Exec's update. When we talk about affordable cost base in future years, is that updated for assumptions post spending review increases or from pre-spending review? Because the NHS got a funding uplift through the spending review. Has that worked through into our MTFP yet, or has that still got to work through?
We've worked through as much as we know at the moment. So what we are, some of the pieces we're just waiting for in terms of the NTP is around what the allocations will look like over the next few years. So we should have a good indication where they come out in terms of what the budget settlements are going to look like for health.
And that'll crystallise our assumptions or not?
It will.
Yeah, thank you.
So, I mean, just to sum up that conversation then, Catherine, Naden, there's more modelling to be done and we need to know a bit more. But this point of the run rate on workforce reduction, not slipping any further and being in as good a position as possible for next year is really vital. Catherine, then Aidan.
So sort of with a sort of a framing of better system working and also how do we spot the opportunities to be different. I do think I think a shared impact assessment of what your plan actually means would be very helpful. Both because you can't do what you're doing and not have impacts, because I'm doing similar things in my own organisation. I'm definitely having impacts. So I think there's a bit about like, let's actually just name them so that we manage them visibly together. But also, I do think that sometimes that restraint is what offers the opportunity. And it would be a shame for us not to be looking at where actually that's yielded some interesting results and we can do something about it. So I think perhaps coming around that and coming up with a framework for it both offers up opportunity, but it also helps us manage it better together.
Yeah, it's a really reasonable point.
Yeah, I'll kind of echo that. Alison and I had a quick conversation before about, certainly through the finance leads, understanding the plans for this year, the array, you know, we too have pumped the brakes as an organisation. What's the impact our action is having on the NHS? And in particular, it's spotting the unintended consequences as well. So I think there's a finance network to be resuscitated, isn't there? And we're sort of committed to do that. I think that'd be really helpful.
And what are the most likely impacts? I suppose tightening CHC spending for the ICB with 42nd highest spend in the country or whatever it was is going to have impact, and that needs to be thought through. On your side, obviously we want to understand social care packages and no criteria. Are they probably the two big pressure points where we don't want to damage each other?
Yeah, and we're seeing kind of like visible impacts in terms of like on individuals in communities, which I think needs to be looked at systemically. I think I've got a nagging concern about that fragility of where we're commissioning into community, that actually actually a little bit of restraint suddenly makes what is a fragile model non-viable, because they don't pick up on just one funding stream, they look at a lot. So it's those kind of vulnerabilities I think we could be looking at together.
So the finance directors meeting and discussing this across the partnership is a really good thing for us.
Yeah, absolutely. And if we kind of look at it in totality and look at the productivity, I guess, of our base across both local authorities and the NHS, if we look in the acute setting, we have a significant amount of unproductive bed base through no criteria to reside, etc. as well. And I know that we work well in terms of making sure that we're able to kind of use the assets that we have from that point of view to make sure we're generating productive activity. But I guess there's that broader point about how we more closely work together and not just from a health and a local authority social care kind of silo as well going forward. So I think that there's a broader conversation through this route that we can.
It's a really good discussion. Thank you, Alison.
Something about we started having a conversation about how do we improve the outcomes and how do we improve the outcomes for the people of Dorset. And you know, for me, we're so interlinked with that, whether it's adult services, children's services, housing services. Actually, they have such a big impact on health. There's so many more I probably should have mentioned, and I apologize for forgetting those. But actually, you know, if we go back to the re-ablement agenda, what does that look like? How do we re-able people from the outset? You know, how do we bring some of these things before there's such a joint agenda for us? And I think that's the bit I'd really like to get in. I know I bended Adam's ear as he walked in. I'll be back to you lunchtime. Actually, how do we create that vibrant conversation between us? I think that's something I'm really keen on in terms of that. And I am meeting Sean. It's in the diary. It's taken us a while to get that one, but it is in the diary. You know, and this is about how do we get our agenda together? And I absolutely agree with you. We can't do it in silos. So how do we get that learning across each other to understand where some of the bits we're doing independently, some where the pinch points, and work those through collectively. So absolutely, you're pushing it an open door.
Yeah, but thank you for raising it. You know, I think it's really important that we have these discussions up front with each other and understand the consequences. Yes, sorry, Dean.
I just wanted to widen the point, I think, beyond finance as well, because it's we're starting from a point of finance, but it then has an impact potentially on services. Catherine already mentioned it in terms of the impact assessments that we've had. There is obviously the commitment that we've got to do the quality impact assessments that we've done. And I think that's a really important process that we're going through to understand all of the actions that we're taking as we may restrict finance in a certain area. What is the impact that that's having on it? Because we know that there are service impacts from that. We can express through the quality impact assessments that we do, kind of what we expect that to be on people, and particularly on vulnerable communities and vulnerable people as well, so that we don't do things inadvertently without putting in mitigations for.
Thank you. That's a really good discussion. Thank you for that. And the earlier discussion on workforce and recovery. Kay, anything on outcomes committee, please?
I'm going to say the paper is largely read. Just a couple of points to pick up. This was our second meeting where we were talking about a digital strategy, and this time we tried to focus down on the role of the ICB in this, in particular regard to connectivity, primary care, perspective, place as being a key issue. This is going to be an ongoing discussion going forward, and as the digital strategy gets past its consultation phase and is actually out for delivery, we'll keep an eye on that and make sure that we do track it as it goes forward and that it is clear as what it's trying to achieve. The other one we had a look at was the new hospitals programme, which hasn't really come to the committee very often in the past. And I think we now need to get past the stage of thinking about all the new lovely buildings that we've got and get back to what the CSR was about, which is a change in the way we operate. So from now on, we need to focus more of our attention on the neighbourhood health, which underpins the whole programme overall, and get back to what we were hoping to achieve overall, rather than just, it's not a building programme. It's not a new hospitals programme. It's part of a reconfiguration of what's happening in Dorset. And we need to now move our attention to that. And that will be where the committee is going in the future to look at those kind of outcomes.
Siobhan nodded a lot, I saw.
I'm smiling. Yeah.
Thank you very much. Yes.
Just a footnote really to support what we've just heard, you know, that we've got to have an out of hospital estate strategy in Dorset.
Yeah.
You know, I was very much part of the CSR and fully supported setting up, you know, an acute a major emergency hospital and the reconfiguration around Poole as well. And you know, I can only wish Siobhan well and her colleagues in actually delivering that now. But you know, the presentation earlier, look at the breadth of services that we are offering. We're all working on top of each other. There is no matching estate strategy for the out of hospital piece of work.
Yeah.
Now we do have a lot of estate in Dorset. We've got a lot of arguably redundant estate, but sometimes we struggle to meet pressures across organisations and between health and local authority. You know, we've got to.
So where are we on thinking about having an estate strategy? Because this will be key to neighbourhood management as well, won't it? And I get loads of questions from MPs saying, what buildings are you going to use and not use? So are we developing an out of hospital estate strategy, Alison or David?
We do have one, but it hasn't been updated probably in about a year. And I think we have greater clarity now on what we think we can achieve through the development of neighbourhood health. And it needs revisiting, because in parallel developments that we heard this morning have been going on through the expanding roles in primary care, and we haven't really fully taken account of that. So there's more to be done.
I suggest at an appropriate time we have a board item on that in order that we can check for so that the thinking is developing at the pace it needs to.
Yeah, thank you.
Alison.
In there for me, and apologies, I'm probably more at favour with the Somerset one than the Dorset one, so I do apologise, David.
It's all sets.
It's a bit for me about how do we use the estate to enable some of the work that we're trying to do. And I know we had our first cluster finance meeting this week. Very exciting to meet everybody across our cluster. And that was one of the things we were talking about, because there's probably pockets of it going on across the 3 ICBs. But how do we pick that up and then run with it? And what's that, strategic estates partnership we need to start looking at? How does that involve the whole of our one public estate to make sure we got that vibrant estate? So I think there's a lot more we need to do on that. So it's a good idea. We probably need to go back to refresh and apologies, I don't know what we've already got in terms of that refreshing, but I think we're probably at that point where actually it's such an important enabler, we need to go back to it.
That sounds great. Does that involve local government before I bring Catherine in? Yes. Good. Catherine.
I was going to say, so like having had slightly traumatic experiences of this, the two things I say is, one is if we can align with our local plan timetable, it will be very helpful, and we're in a really good spot to do that. So secondly, is if you're going to bring something back as a board item, could it include governance routes? Because my experience of this is that we've all got lovely ideas and no bugger can take a decision. So being really clear about how is it we would get something away and starting to admire the problem of that early, I think would really help us actually get into delivery.
Thank you. Really helpful comments. Forbes.
I think, back to the other discussion about finance, this is where everyone's got to have skin in the game, haven't they? And I know there are processes that are different for the local authority as for health, but actually, we've got to make it work for us.
Yeah, completely. Really helpful discussion, Chris.
Yeah, thank you. And a broader point on that, of course, as well. So previously, so this financial year beforehand, there's a system allocation of capital. Actually, through the medium-term plan, if we look forwards, actually it's now at provider level as opposed to overall system level. So there's a broader point around the principles that we develop through partnership working to how we kind of assign capital regardless of where it's allocated to make sure it serves the population as a whole.
Thanks very much. Anyone else? Thank you, Kay. And so, Carl, anything on People Committee?
That's fairly straightforward. It's probably just worth noting that at the time we had the meeting, the context had changed and we were looking at the introduction of masking. So there was no VR. Now that's changed again in the last couple of days. So I'm sure when we get to the next meeting,
there'll be something else
yet again. But we did have a good set of data to talk through, which was really helpful discussions. We've agreed that we'll continue to have some of the Freedom Speak Up data included in that and the Pulse survey data as well. The other thing to note was the good collaborative work across the cluster as a whole, which helped with the mitigation of the second risk around leadership and organisational change.
Thank you very much. Any questions, please? Thank you very much, Carl. And
Robert, just a comment, really, just as the board in part one, just this paper. I think we just need to be mindful of the staff, and we should note it in all of this. We are, I'm not an employee of the ICB, but for those who are employees, the amount of turmoil that's been going on in recent months for them as individuals is huge. And I look at some of the people in this room, the uncertainty, and then to have the changes that you're talking about. This is not easy. And you do see people have left, you see people basically trying to keep the show on the road. And it's very, very difficult. And, you know, we want to move through this as seamlessly as possible. But I think the board should just acknowledge the difficult situation that individuals are in.
Yeah, no, thank you. I mean, look, we have to take responsibility and accountability. But it's probably the most unfortunate way of doing things I've seen in my career, isn't it? Marching people up the hill and then down the hill again and then up the hill again. It's very difficult. And so it's like I said at the beginning, David, it's not just hollow words. I think what Forbes said is absolutely right. We really appreciate, through you and the executive, to staff, please, the difficulty that people are going through.
We did discuss in there about making sure that the support was signposted and was available, and,
yes,
you know, to sort of keep that kind of common. The narrative, which is why it's important to get the pulse survey data and the freedom to speak up come through as well.
Does part of our package include outlets and support and things like that? We're doing all of that. Adrian.
Just to a completeness point, I mentioned before when we were talking about BAF, the fact that transition risk is a big strategic risk and it's being managed under a separate risk register by the transition committee cluster, which is accountable to this board. Those risks are writ large on that risk register, and there are mitigations against them beyond, you know, expressing sympathy and empathy, if you like. There are engagement actions, there are communication plans, etc. It doesn't detract at all from the fact that, you know, kind of agreement with Forbes and you, Rob, which is, it's very unfortunate that this is the way it's been managed. But there are, I think, from a governance perspective, good actions in place to try and help to mitigate the risk.
Thank you. Anyone else, please? No one online. Thank you. And Rhiannon, anything from quality, please, as escalation?
Yeah, I just obviously take it as read, but just do want to pull out a few things, if that's okay. The concerns around, which has been highlighted before, closure of Yeovil, but the ongoing impact on DCH. And in addition to that, the fragility around some community pharmacy provision, as in Jehoots. I understand it's a national issue. There was particular concern expressed around the Lyme Regis area, but we did take, and I'm using the word deliberately, reassurance that other pharmacy providers are still providing services across the county. The one thing to just, we were seeking assurance, I guess, from provider representatives that are in the committee, particularly around the voice of carers being at the centre of any out-of-hospital design of out-of-hospital care, and that there's a clear understanding of the impact on carers when we're creating these other approaches to providing health care. To just say that we did deliberately take a decision that we were going to explore from a quality and commissioning committee perspective, or develop, let's say, our collective understanding of strategic commissioning approach, informed by the new framework. It was in draft at that point. Obviously, it's now fully approved and out there. We used a bit of case study to inform that, which was a CYP mental health, or children and young people mental health. And some of the things that came out, I won't go into all of them, but some of the things that kind of were highlighted were around capability requirements in particular, interdependencies between the ICB and the provider organisations, obviously. But we talked about ICB readiness, but equally there needs to be provider readiness to kind of be ready to be commissioned, so to speak. In terms of the commissioning intentions, which was a later paper, we endorsed the commissioning intentions, which appear to address known and emerging risks. Obviously, that's on the agenda shortly. And just the other thing to flag, in terms of the corporate risk register, the quality and safety perspective around a quality risk, which is related to clustering, and that's been escalated to the transition committee. and also an emerging risk around the maternity advice line. And just to say, in relation to our Bath discussion, we talked about a kind of aggregated risk in terms of quality and safety impacting on inequalities. And Kay, as the chair of the Outcomes Committee, sits on the Quality and Commissioning Committee, and we agreed that that would be, we'd ask the Outcomes Committee to look at that further. That's it, I think, Rob.
Yeah, brilliant. Thank you very much. Any questions or comments? J Hoots is a national problem, but particularly the southwest, David, wasn't it? There's a lot of prevalence, so it is important to highlight it, as Rhiannon did.
Yeah.
Paul.
Yeah, so we are looking at that from a quality perspective, both here in Dorset, but also there's been a regional group that has been convened. So far, I mean, we have two areas I would say are most stretched by this, because we've got 6 J Hoots pharmacies, all of which are closed at the moment. But 4 of those are within larger conurbations where there are easily accessible alternatives. But Lyme Regis and Shaftesbury are the 2 where we see more fragility, and we're working on alternative providers there. But in the meantime, we have got mitigations in place from either remote access sort of delivery options or neighbouring towns. It's not ideal for our patients by any means. We're also looking to see whether there are any harm events being reported through the national scheme, and there's none come through yet. Right. But we're encouraging practices and individuals to report that they experience them. But there's anecdote, but there isn't any actual evidence at the moment. The other bit that we're working with our local authorities on is access to opiate replacement opiate therapy, and those who were affected have been moved successfully to alternative pharmacies and so continue to receive.
I know there's a considerable amount of mitigation work in place. So, thank you for that, Catherine.
It would be really helpful to have sort of an overview of the mitigation plans, just because we're getting a lot of understandable concern about it, and just having that kind of like that detailed information would be really helpful.
So who do you want me to link our team in?
If you were to link that in with Sam Crowe, Director of Public Health, that'd be helpful.
I think I'll do that.
The other thing is particularly in terms of where the transport is an issue, since we're trying to really review where is it we need tactical, community or strategic transport options, and so this kind of really highlights where that's the biggest problem.
Thank you. Thank you, Rhiannon. Thank you for highlighting that. So we are on to item 17.
Thank you very much. In terms of the performance report, so we continue with the generally good performance, as you'll see from the report, that we've got on delivering against the national operating standard. I'm pleased to confirm that we are not been escalated at all, so the tiering process that exists, so none of our services are in the tiering process, which is a great achievement for the system. We've got strong performance, particularly in elective care, where we have reduced the number of long waiters, and as we sit today at the end of the month, we are only expecting kind of 1 patient over 65 weeks, and that's due to the availability of certain things that are needed for that individual, rather than capacity issues that we've got to see the patients. And also mental health, primary care and inequalities, that we have got good performance in. The area where we are slightly under is in cancer, so there has been more referrals over the summer period, and our performance of treating patients within the 62 days has dropped because we are treating a backlog at the moment. That's expected to have worked through by November, so this month we're expecting to see that back. We had our plans reviewed by the regional team, and they have come back assured that we've got the right things in place to recover that performance. The area that we're seeing the most challenges in, almost as you would expect during the winter period, is urgent and emergency care. So we had got, during the mid-year review process, University Hospitals Dorset have resubmitted their A&E plan for the 4-hour target. That's been accepted by the regional team. I think the area to highlight, which we have spoken here already today and many times before, is no criteria to reside. we did see a significant rise in the number of people who were ready to leave hospital and weren't able to in early October. Two reasons for that: mainly start of flu and COVID season earlier this year than we expected, so there were a greater number of respiratory patients in the system, and we were also then needing to get those people into intermediate care afterwards, of which there were some bottlenecks during October for that. But we've responded well, so the future care programme that we've got has got the right data to show us where we needed to focus our effort on, and so that's what we did, and the numbers have come back down. We're not quite at the summer levels yet, but we're back down to a much reduced level of no criteria to reside before we get into the colder period of winters. On ambulance service response times, we had seen 3 months where the category 2 response, so that's where it's an urgent response is required, not a life-threatening one, but an urgent response, which is 60% of the activity of the ambulance trust, was worse than planned. We requested a plan from them. They put that in place. The main thing that they've done is where it's a handover, because we were seeing an increase in the time that it was taking to hand over patients at A&E departments across the region. This is not just in Dorset, and we have seen an improvement of their response times of 3 minutes improvements during October, and during November so far we've seen an extra 2 minutes on top of that as well. So the plan that they've got is working for ambulance response times. They're still not at the level that we want them to be in the operating plan, but they're making good efforts towards doing that.
Very good, thank you. Questions? Okay.
You'll not be surprised, Dean, to say I'm going to ask about the CYP access issues, because the trajectory there is continuing to slip. Now we've got a business plan in place and we've got a whole transformation of the service in place, and I know there's been an issue about investment in that, and I know that the recruitment targets are not being met. How long is this trajectory going to continue to slip? When do you think we'll begin to see a bit of a turnaround? Because it was in crisis already and it's just slipping further and further.
Yeah. This one, it's another one where we've put a plan in place for it. So we have got, we're still working on what that trajectory looks like, because it's a 12-month rolling picture that is the measurement for it. So it takes quite a while to get through. The investment that we've got going into the services, that's one of the impact assessments that we're doing to make sure that what we're doing through the financial plan maintains and recovers this position with the children and young people. I'll have to come back to you with the trajectory. I'll include that in next month's report.
Thank you.
So that we've got that.
Thank you, Dan.
I was going to ask a question on the wider performance pack, not on the performance quadrant. Is that for now? Or is that...
You can do that now. Yeah.
So I just wanted on workforce, which obviously sits in Adrian's committee, but for the board paper, I think there's an error on page 75 in the third paragraph where we're mixing up DHC and DCH, and I think we should correct the paper because the summary doesn't accord to the graphs that are in the actual pack. So I think we should correct that. My question is then, there's a comment in there around the two organisations that are over substantive that we will introduce tighter controls as a result. And it reads as though we'll do that as a result of substantive, but we therefore won't pick up DCH, agency and bank overspend as part of that. And I'd understood that we'd introduce these controls at the start of the budget, given how much kind of SITs relied on the current workforce reduction. And so I guess I'm looking for some assurance that what are those controls? How are they different from what's meant to be in place already? And why are they only focused, the tightening, on substantive, not on whole workforce, agency and bank? It's a really wide question. I'm happy to kick it into committee, but there's just something about that grip that's come up a number of times.
Bruce, did you want to cover that now, or do you want to? Should we raise it at committee? Well,
I'm happy to give a brief response.
Yeah, please.
That's helpful. So I'm certainly talking for Dorset County Hospital and Dorset Healthcare. We have established, in line with H2 recovery, a financial recovery board chaired by Matthew, the Chief Executive. One of the key areas of focus and key line of inquiries is around workforce, looking across the board at substantive, bank and agency. So we are looking at in totality, recognising the total workforce figure, of course, includes all of those elements. So you can't be looking at one in isolation. We've got robust controls in place as described through substantive, through vacancy review panel processes, etc. Agency actually across both organisations has seen a massive reduction over a period of time. However, bank naturally is an area which is more cost effective than agency. It's still temporary staffing. We do have good controls in place for that, but being the area that is overspent is getting a significant focus through our internal kind of committee route to make sure that we're able to do that as well. And that's reflected through the revised trajectories that we discussed previously too.
That's really helpful. And Siobhan made similar comments in the last item. I think they sent something for the ICB, the cover note on the performance part, making sure it's accurate and is rounded out for those things, because it doesn't quite read with that level of assurance.
Very good. Thank you for being so thorough. Adrian.
Just to follow up on the same point, there was an echo in your comment on workforce to the update I gave on recovery plan. I think Chris would probably nod at this, but we had a pretty brass tacks conversation at the recovery plan finance committee, which is we shouldn't be into a recovery plan. Yeah. I think, Dan, there's an element of the workforce plan for 25/6 was pretty level in the first half of the year, and then it was to reduce significantly in the second half of the year as the shifts were delivered. You would see the people coming out, and we're hitting the point in the plan where people start to come out, and actually the underlying improvements haven't all come through, and there are other complications which don't need to rehearse here. But I think that really the need to amp up the workforce controls again is almost under the spotlight because of the fact that we are not now expecting second half WT to be in line with the trajectory of the plan, which is one of the reasons why the Finance Committee asked for this monthly reporting against the trajectories that are in the recovery plan, including the WT trajectories. So I think it's an important point that we should capture.
Well, it is, and we have to learn our lessons, don't we?
Yeah.
Workforce plans that expect delivery in the second half of the year tend not to work. And your workforce reduction should be agreed and in place and planned before the start of the financial year. Otherwise, you're running a risk of slippage when you're in year. We've got to learn that lesson, haven't we? Every year, we're deferring some of this to the next year, and then history repeats itself. And the truth is, in most organisations, you would not go into the year without those things already being agreed in order that you're simply implementing them. Sorry, sound like an accountant. Any other points on the? Can I ask about the discharge? So you mentioned no criteria to reside. Now that they're sort of matured and we're post Newton, how are they working, Dean? We had as I remember it, they sort of got off to a quicker start in the east than in the west than in the east. But how are they working now, and have they delivered what we need?
Well, we have now got substantive appointments into those. So we started them earlier in the year with kind of temporary arrangements. So as the Newton programme kind of set off, they got the model working, tested it within DCH first, got that model working, and then transferred that over to UHD. So they now have got their substantive staff in place. So they're now kind of business as usual, and that is really the engine room of how we will reduce the no criteria to reside. So I think they're working well. The professionals working alongside each other are now in physically one location in the main, and so are working well. And we're seeing a reduction in how long it takes the patients that are coming through to be allocated to where they need to go to in the next part of their journey.
Okay, thank you.
They're working well.
Thank you very much. Any other questions on performance?
Yeah, Rob, I've got my hand up. Can you hear me?
We can hear you.
Yeah.
Yes.
Dean, just a question around the ambulance performance. A lot of emphasis on their improvement plan, which I totally get. But I just wondered what emphasis has been put on the providers in terms of obviously they have a big part to play in terms of timeliness of handovers. So I wasn't hearing that when you did your update. So I just wonder what we're doing to kind of, pull those levers as well.
Right, that's probably where the biggest improvement has been in the handover times. The handover times within Dorset have always been good, kind of the best in the region. It's a smaller number of hospitals outside of Dorset that have been where the ambulance has been queuing. The trust has agreed with every hospital across the southwest that kind of they will implement their handover protocol at 45 minutes at the maximum. So if once a patient gets to 45 minutes in ambulance, there will be a process to then move that patient into the hospital, and that's where we've seen the greatest improvements, where the kind of average handover times have come down now to about 26-27 minutes for handovers. The target is 15 minutes, is what we always used to work to, was 15 minutes, but it has been over an hour as the average earlier in this year and in previous years.
That answer your question, Rihanna?
Yes.
Yeah.
Kind of, yeah.
All right, thank you very much. Thank you, Dean, for the report.
Yes, can I just ask, so if you don't mind?
Oh, I'm sorry, so sorry.
So I welcome the reduction in the ambulance handover times, because it basically puts ambulances back on the road to be more responsive to people with more acute need. Is that improved as a result of better flow in the hospital, or as a transferation to more trolley waits?
It's that handover process in the emergency departments. Now, sometimes that has meant that they've needed the additional spaces for the patients to be allowed out of the hospital. So we haven't seen any further increases in incidents of problems of people being offloaded in that way.
But it can, can't it? It can happen.
I mean, I agree with the approach. I think especially if the ambulance is on the road, you know, to deliver care, but you can't just transfer the problem, can you?
Yeah.
Because it used to be trolley waits bad, or we'll have ambulances waiting. Okay, ambulance waits less, but we just shift it into trolley waits. It's about the flow through the whole system.
It is. Thank you very much, Dean. The committee work plans we've read, shall we take them as read, or just if there's any questions on them and agree them all? Everyone happy with those? I didn't think we needed. I think take your presentation there. Everyone happy with them? Thank you. We'll take those as agreed. That gets us on to commissioning intentions. We could probably ideally have a day on this rather than 15 minutes. And maybe, Dean, the thing that came out of the earlier discussion about how do we translate these commissioning intentions into real change? Your thoughts?
Thank you. So, I mean, this has obviously been it's not a very long journey, because we haven't had a long time to actually produce these. But in Dorset, we have produced commissioning intentions every year since we've been an ICB. So we've had practice of doing this. We normally do them as 1 year intentions rather than 5 year intentions. So we try to look a bit further ahead for these, so that the intentions that we've got. We've used a lot of intelligence as well to produce these together. So there are kind of the local plans that we've got, so future care, integrated neighbourhood teams, the changes that we've got through the clinical services review are reflected within there. We've used changes in policy that has been available to us, long-term plans, national policies that are in existence. We've checked these out with providers and with local communities, but we've also used the quite extensive public feedback that we've got. So we didn't produce a document and went out to local communities and said, what do you think to this? We used all of the data that we'd got from previous engagements, through the 100 voices, through what we've been told previously, to do an analysis of what is concerning for our population, and that's been included in the report. We've then checked it back with the chair and the groups that we've got, and they've said yes, this chimes with the concerns that we've got, so to make sure that it's still current. So that's the process that we've been through on that. It's had extensive discussion within the ICB. It's been with our providers and partners kind of over the last few weeks or so, and we're now going through and refining that as well. It's been to the Quality and Commissioning Committee for a discussion there. And now it comes to the board for final discussion. Your question in terms of how do we then put this in practice? Well, we put that in practice through the commissioning that we're going to do over the coming year, but also the contracting that we are going to be agreeing with all of our providers over the coming weeks before we get to next year. And that's how we enact the intentions that's within that. So there are, for me, there are kind of two types of things within the commissioning intentions. One are where we know we've got agreements on and we know we're going to put into contracts for next year, and other things which are more longer term intentions that we are signalling that we want to achieve. And we've split the document, we've tried to structure it in terms of the 3 shifts that that there are in the 10-year plan. We've gone probably a stage further as well, now that we are clustering and we have started to compare what the 3 ICBs are doing in terms of their and there's a lot of synergy between them. So as we come together as a cluster to create a single commissioning intention plan for the cluster, it will be easier to bring these things together.
Yeah, thank you very much. When we discussed this at the Joint Transition Committee, there were a lot of similarities across the 3 clusters. What do we do about dentistry in rural areas is clearly going to be something we're going to have to give massive thought to. I suppose the controversial bit of the discussion at the Transition Committee was, should we set some financial targets as part of our commissioning intention? We spend 52% of NHS money on the acute sector. Should we say that over a 5-year period, we expect that to go to 40%? And that's going to be reflected in our contracts in order to drive more resource being spent on prevention and neighbourhood health. And that's quite a controversial thing to say. But what are your thoughts on that?
I think the way to answer that is the next stage that we've got to produce is a 5-year plan. So the next stage of the medium-term planning process is a 5-year plan. Got quite a tight timescale to do that. So there will be a draft coming to the next board for that before we sign it off. But I think that's the process that we need to use to actually answer that question, because I think you're right, it's right to set those, but we need to set them intelligently, not as arbitrary.
Yeah, shall I take 40% as agreed? Catherine and then Adrian.
So love the idea of like actually what is the intention of moving the money around the system. Just a really practical thing. So I'm a technologist by trade. My slight concern in the framing around the digital stuff, this is not the way to buy better technology. So it may be that what we need is a stronger connection into that digital strategy, which what are the building blocks of capabilities that need investing in order for these, which express more as outcomes than actual kind of like commissioning decisions would be able to do. So I feel strongly about that. The other thing is just, and I'm happy to talk more about it because it's my thing. The other thing in there was going back again to the conversation that we had earlier about making sustainability of community settings part of our commissioning intent, in order to make sure that what you're not doing is layering services on fragile models, that there's something in that intention around the community space, that we're acknowledging the need to contribute to overheads, the need to consider their need for long-term planning. And then the last thing is there's something in here which is where I think it's on the edge of your system, our system, which is we do a lot of work around market shaping. It would be very good if this kind of strategic intent was actually, really uniting that, because so many of our long-term health conditions are down to good work, for example. Yeah. And how are we using this kind of decision making in order to drive very different outcomes? So I think a stronger flavour of that I would love to see.
That's really, really helpful. Thank you on all of those. So Adrian, and then we have Rhiannon and Paula.
I'm not stealing Rhiannon's thunder. Just a reflection on our conversation on this topic when in committee we did a first review of the document. We didn't come up with 40% as the kind of incendiary soundbite, but we did have a really good and candid conversation with providers in the room to help us about, kind of whatever number you put on it, there needs to be a shifting of resources, and whether that's kind of holding acutes whilst others rise to change the percentages or whatever. But we identified that it was going to be very important for that to be a collaborative effort, because what you wouldn't want is exiting a whole load of expertise in secondary and hiring a whole load of equivalent expertise in primary, and if ultimately rehoming the capability closer to citizen is a structural change. That doesn't necessarily mean downsizing and upsizing. It might mean reallocation and redeployment, which is the reason.
It has to work for the acute sector. This is
Absolutely.
yeah.
Just to give you some reassurance, if you like, Rob, that at committee we were pushing the buttons without the numbers.
Thank you very much indeed. So we have Rhiannon and then Paula and then Siobhan.
Thank you. And no, Aidan, you haven't stolen my thunder, but it's sort of linked point to the conversation that's been that started. So specifically, Dean, at 2.7, you've got that really helpful grid to look across the cluster context in terms of commissioning intentions. And I was just curious about the bottom of that grid where it talks about payment approaches, and it reads, and perhaps I'm just misreading it, that BSW and Somerset are kind of, thinking about payment approaches, really thinking about that left shift, whereas the middle one for Dorset, we're talking about business as usual. And I just wondered if you could say a bit more about that. It may just be the wording or my reading of it.
I think it just reflects where we are at the moment. It's not and I think that's where it's helpful to compare the three, so that we can actually look at what's happening across the others, because it might be the way that we've just expressed it. We think it's business as usual, but actually, and we might have made things some earlier movements than the other ICB. So I'd agree, Rhiannon.
There is opportunity, Rhiannon, for cluster learning.
It is, isn't it? Yeah, because what it was saying to me, it looks like we're not as ambitious as the other bits of the cluster, but we are. So I think it is framing and capturing that, or we need to be if you don't feel we are at this point, but I'm pretty sure we are. Thanks.
Yeah, no, that makes sense. Thank you. Paula and then Siobhan.
Thank you. I wanted to sort of, first of all, agree with Catherine Howe's statement about sustainability when it comes to VCSE contracts and procurement, and just making sure that the service that you think right now is suitable will still be there a year or 2 years into the plan, because the fragility of our sector is more acute because we don't have the buffers of profits, shareholders to be able to sustain our organisations. Also, it was mentioned within the funding about the idea of lead provider models and subcontracting, which can include the VCSE. I would just like to warn that there have been instances of this done in the past. And what happens is that lead providers put down their intention to work with the voluntary sector as part of their bid, and are successful in getting their money as a result of doing that. But actually, there's been no flow of funds that then come through to the voluntary sector groups that have been part of the bid. So we need to ensure within the bid that those flows of funding down to those subcontracting voluntary sector organisations is inbuilt in and not just implied within the contract. And my last point was just about the Oliver McGowan training, and it highlighted the importance of compliance with that, particularly in successfully delivering community care for people with learning disabilities and autistic people as well. And I would say that we're not compliant. The take-up has been quite low in some areas, and there needs to be some proactive approach to be able to allow the capacity for staff to be able to do the training. Or what we're going to find is that we don't have readiness to provide in that community-based care for people that are so disproportionately affected by health inequalities.
Thank you very much. Really interesting points, and particularly around the sort of sustainability and follow through to seeing that happen. You may want to comment on that, Dean. And finally, Siobhan.
I just wanted to say, Dean and the team, this is like, you can sense, having been here for a few years now, the real shift this year in the commissioning intentions. And I think that is really incredible, considering all the change that everybody is going through. And you can see actually the benefit of working as a cluster. So I sort of saw some real positives. I suppose I did hear you mention it, Dean, but I will just ask, on the clinical service review, especially things like the urgent treatment centre at Poole, just assuring me that we are sort of in line as we enact those changes next July, because a lot of people are sort of watching closely.
Yeah, thanks for all that, Siobhan. Dean, I'm sorry, should we take Forbes and then you can finish, Dean?
Yeah, just 2 things. Back to your original question about the financial issues. You know, bottom line is I think there has to be. It might not be disinvestment, it might be relative differential investment, and you just need to think that. Otherwise, certainly my colleagues and others read this, they'll say it's not credible. So how are we going to do this? And often it's about, it's not also that, it's about the shift in the skills as well, because you need additional skills to deliver the greater complexity that you're being asked to deliver. And unless you, because everyone just say, well, where's the money basically? If it aligns, and it might be very, very small, then you get much better traction, quite honestly. And people then think you know there's support, genuine national support to make this happen. The second issue, just if I could touch on the Oliver McGowan training, because I think it is become a topic of quite a hot topic in practice at the moment. And everyone's absolutely hugely supportive. So it's not about the training, it's just the ask there now is basically all patient facing. So largely clinical staff to spend a day doing the training. And we're trying to work out the best way to allow people time to go and take a day out of clinical work to do the Oliver McGowan training. So we're looking at ways of trying to make it happen. Nobody's against doing it. It's just the practicalities of delivering it.
Thank you very much. Dan, I'll let you in, and then sorry, I'll have Dan and Chris, and then
one question. I really support Rob, your and Bob's points on let's quantify the intent. I think I heard from the room a bit of a that comes later when we get to the budgeting round. I think if we're not going to quantify, I get it's complicated. I get there's loads of moving parts, but I think we should really force ourselves to quantify those 3 principles or some of the principles. And then the question is, are we loud enough in here on capital? So the finance requirements, it does mention capital, but it largely focuses on revenue. We've talked a lot about community, using capital, change of services. So I wonder if there's something about how we spend and prioritise our capital to deliver the commissioning intent. And should we say more in this document on those principles? I think the finance principles are largely P&L rather than balance sheet.
Very helpful, thank you. Lastly, Chris, and then we'll come to Dean to sum up.
Yeah, thank you. On that point briefly, I agree. So how I read this in terms of the the shifts and the talk about neighbourhood health, etc., you have to have the infrastructure in place to deliver this, not just the revenue expenditure able to in order to do that. So I think when we get into how this actually becomes deliverable, that's exactly what we need to be looking in. In terms of just a broader comment, I completely agree with what Siobhan said. It does feel like we've had a step change in terms of commissioning intentions this year. And also the alignment to the 10-year plan is really key in here. And it's really good to see that our systems priorities, broadly aligned to that. And actually, we've already made quite significant progress across a few of the pieces. I was going to probably make a similar comment to Rhiannon, which is, good ambition in terms of what we're saying from this. Obviously, we haven't had our financial allocations into next year. So in practice, how do we actually make sure that particularly as we're looking in the health sector at organisational financial control total, as opposed to a broader system control total, how do we collectively own this and make sure that actually we are appropriately pushing the funding streams into the areas that we collectively agree are our priorities?
Thank you very much. Dean, I'd like to sum up.
How do you sum up that lot? So thank you. I mean, it's really helpful.
Really good comments.
Really helpful comments on that. I think, Catherine, just picking up, and this might be a slightly different shout, but the market shaping element, there are certain things that we have done in the last year in changing the landscape of the type of providers that we are working with, particularly through problems that we've had, things like ADHD assessments and different community providers that are out there. And we're trying through the contract mechanisms that we've now got to try and shape the different providers that are available to us to do that beyond the traditional services that are provided. And I think that's probably only one element of what you meant on market shaping, but it triggered a thought for me just to say that that is almost one of the intentions within the way that we commission, is to change the landscape of the type of providers to deliver the type of services that we want and the changes that we've got. Really take the point on what are the numbers that sit behind this. We haven't got the allocations yet, but really take the point on how we want to demonstrate that we are shifting between them. And kind of, I'll look with Alison, we will kind of look to see how we can do that for it. I'll ask for a bit of help on that one. Payment mechanisms, definitely we're looking at different ways of how we pay for things, the development of outcome-based contracts as well, as we look at different specifications that we've got, moving towards more of an outcome rather than input payment mechanism for that. I think that's really helpful. Lead provider models, I think we've got some great examples in Dorset of lead provider models that has engaged the voluntary sector. So the Access Wellbeing Service, the children's and services has been, I think, a real model on how we can use a lead provider to develop the voluntary sector to provide services, and that particularly first line before we get to kind of some of the more specialists that need more clinical skills. So I really welcome that point, Paula, and we'll want to build that into it. Thank you for the feedback on it feels different, because I think we have done this, but they've been mainly contracting intentions that we have issued previously. Almost the environment that I think we have been in within the last 2 years has kind of forced us down that route. The environment that we're working in now, particularly with the change of government that we've got and the approach that we've got through the 10-year plan and the strategic commissioning intentions, is something that we need to has changed our thinking on how we do that. Siobhan, you mentioned the kind of UTC at Poole and the clinical services review that we've got. Yes, we see that as an underpinning part of sticking with the judicial review that we have got there. There are lots of challenges that we've got to work through on how we do that within the resources that we've got. But the intention is very much we stick to the clinical service review. Sorry, CSR, kind of working in government, always has a different connotation for it, which changed by kind of comprehensive spending review is what always comes to mind.
Yeah, it's what I always think.
Sorry, I was getting slightly distracted by my own mind there. Forbes, you mentioned the skills for this, and it's really important. I think what we've seen particularly over this year's operating plan that we've got, there was a need to do something very different and commission services that changed the cost base of it. And I think that's where we've seen that our skills are not as good as we thought they were. And that's the new commissioning framework that's come out is coming with a development plan for organisations, a maturity matrix for organisations, but also developments for individuals as well. And I think it brings back the professionalisation, hopefully, of commissioning, which has been lost over recent years. I think there was a tendency to move towards procurement as the skills, as there were national frameworks put out, and the instruction was go and procure services rather than use the data that's available, do your population analysis first before then going out what your commissioning process is going to be. Quantifying the technical covered. Capital, yes, I think that can be signalled within this, but probably needs to be followed up with a capital plan. We've already talked about that earlier in the meeting for part of it. And I think I've covered.
You have
the main points.
Okay, everyone happy? And Dean, you still have the floor. You're going to cover medium-term planning for us, and then we'll just close the meeting with the usual formalities.
Thank you. Could I just ask on the commissioning intentions in item for decision, are we happy?
We are happy to agree that.
Thank you. Just so that.
No, you're quite good.
Thank you. And the last item on medium-term plan, we got further guidance. Guidance seems to be coming out in a number of documents with this. We originally had kind of just the original framework, and then the 24th of October, we had the medium-term planning framework, which covers the next 3 years. It's kind of details are in the paper over what's in that. So kind of 3% increase in revenue, 3.2% in capital. It is a 3-year plan. Really, the emphasis that has gone through the whole of this meeting is on having balanced plans financially throughout it. The requirement to deliver 2% efficiency. There will be further, and I don't think we've received them yet. The allocation was due out last week, if not the week before, and we are still waiting for that, which includes the way that we construct contracts. So at the moment we have block contracts for part of it, particularly the urgent and emergency care element. There is an intention to dismantle that process and come up with other payment mechanisms for next year. I think one of the fundamental parts of planning this year is a move away, Chris, you mentioned it earlier, system control totals and a system plan to organisational plans. So where we currently just produced a Dorset plan, we now produce a plan for Dorset residents, for our resident population, and our provider organisations will provide an operating plan for them as an organisation. So there is a clear big overlap between those, but they're not the same thing. So the way that we need to construct our plan this year is by all the different providers that we work with, so that we build up the plan from that basis of how we commission our services. We will focus particularly on the commissioning of that and kind of any demand management that needs to be put in place. So working with particularly GPs and those that are referring into services. There's 15 focus measures that will be used by NHS England to demonstrate improvements in health service. We need to submit our first plans on the 17th of December. You'll see in the documentation it said 18th. There's been a change of date for that. So some of the dates do say the 18th. I think it was actually 18th in the plan that was released, but it has been moved to the 17th, which is important. One day kind of doesn't seem an awful lot, but when we're putting in finance and planning committees and board meetings, we often have that either on the day or the day before. So it does have seismic implications potentially on the way that we then put the plan together. We've also included an update on all of the items that the original planning guidance needed to be in place. So we've assessed ourselves against that, and it will all be overseen by the Finance Committee as we go through the next few weeks.
Very good, thank you. Any questions or comments, please, Dan?
Thanks. It was really helpful, really clear. The bit that I really like was paragraph 210, Dean, where you've done the look back on its delivery confidence. Can you just tell us a little bit about how you've done recent history, kind of projecting that performance into delivery confidence? And then a specific question on that. I couldn't see no criteria to reside or virtual wards in the new 15. And do you know why they felt missing, but it's obviously central guidance? And it'd just be good to understand that a little bit, please.
So no criteria reside hasn't been in this year's plan either. It wasn't one of the measures. So I think there's been a real desire and a welcome desire to reduce the number of things that are monitored on a kind of daily basis, which no criteria to reside was, into more of some of the outcome measures. So it's kind of how we're responding to urgent ambulance calls, how quickly we can see patients within accident emergency departments. So I think it's just more of a desire to cut the number of indicators that there are and focus on the outcomes rather than some of the more process measures. Something that we continue to monitor, and we do that through our future care programme. We've now, by next week, we will have agreed trajectories over the next year for our no criteria to reside, working on looking at the plans that we've got through future care. So it
certainly is a priority for us, isn't it? Alison?
Sorry, if you don't mind me adding on to that, the no criteria to reside is one of the better care fund matrices. Even though it's not one of our overarching ones, it will come in there in terms of how we work with our local authority to do that bit about getting people out of hospital, not having the admissions in the first place, and better reablement. So it comes in there, but we won't forget it.
Forbes.
Yeah, thank you. Just a comment really. At risk of having too many plans. There's this plan, and the local authority are working in a neighbourhood plan. There are now multiple neighbourhood plans around. And the benefit we had before through the original CSR process, we did get to a single plan with a single narrative that people could then engage with. And I think that's what we've got to try to do. If we're going to work as a single system, we really need to have fairly clear, simple objectives. It's not just a scattergun approach around plans, because there's certainly, you've made the comment just a couple of minutes ago about there's a lot of stuff now coming through, and I think we just need to make sure there's a consistency in terms of these, otherwise we just confuse people and we don't actually achieve what we want to achieve, because
particularly as we get place governance.
Exactly. Yeah.
There we want a single narrative, don't we? Yeah. Really helpful. Any other questions or comments? Are we happy to? Sorry.
Sorry, I didn't answer your first point, Dan, on paragraph 210. So I think the way that we've just looked at that is looking at where we are at the moment, and almost if we didn't do anything different, which ones would we we'll just deliver by doing what we're already doing, and which ones will we need to take some intervention in to actually do something to get to the position that we're expected to get into. And if you look at those, it's particularly around some of the urgent and emergency care ones, and community health service waiting times really refers to ADHD services, where we've got far too long a waits for ADHD and autism assessment. The talking therapies and individual placement ones are ones that are we're having to have a particular focus on at the moment, and have taken a look at through the financial recovery plan that we've got. We need to get back on track with that next year, and we've already mentioned during this meeting the workforce reductions that we haven't delivered over those in the past. Therefore, if we just carry on as we are and do the same things, we wouldn't achieve those next year.
Paula.
Really, just to reiterate the point that was made about having an overarching plan. Now more than ever, we need community and resident buy-in. There's a big shift towards self-care and taking more responsibility over your own health. And so we need resident buy-in, we need patient buy-in. So having lots of separate plans does instantly cause confusion within communities. So something that pulls it together, whether that's something that's done informally or through comms and engagement, but there needs to be that.
Okay, everyone happy to agree with that? Thank you very much. So we are on to the just the formalities of the meeting. There are no further items for consent. Item 11. We do have a question from a member of the public. Is Mr. Marsh online?
I believe he's joined on the live stream.
Oh, right. Thank you very much. So if I'll read the question, and if the answer can go into the minute, please. The question is that on 9th of November, the Department of Health issued a press release stating that major new programme backed by 1.8 million will see NHS staff receive training to identify patients with armed forces backgrounds and provide more targeted, personalised care. Thanks very much for the question, Mr. Marsh. If you're on the live stream, our response, if helpful, is that we're proud that we work with the Veterans Covenant Healthcare Alliance, VCHA, and the Royal College of General Practice Veterans Friendly Practice Accreditation Scheme, with 100% of our practice and hospital and community trusts now accredited. The investment directly supports our staff as the National Armed Forces Healthcare Training and Education Programme is being delivered across England with a dedicated VCHA trainer for the region. This programme is now in place to support NHS Dorset, and their partners receive the appropriate training and education required to ensure that they can develop a skilled, educated and inclusive NHS primary, community and secondary care workforce to meet the evolving needs of the armed forces community. VCHA regional trainers and educators will work with and across NHS Dorset, so we are better able to respond and manage care for the armed forces community, assisting in the development of delivery of local population health. This programme will ensure that our veterans and wider armed forces community can continue to access additional support through our Op Courage and Op Restore for those impacted by mental and physical health. The work of Grove Medical Centre and other practices across Dorset who have embraced the General Practice Veterans Friendly Practice Accreditation Scheme, connecting with the armed forces community and signposting them to other community assets to support their wellbeing, reinforces our commitment as a board to support our armed forces community during this week of remembrance. Thank you very much for the question, Mr. Marsh, and I hope the response demonstrates how seriously we take this. If you have any follow-up to that, don't hesitate to contact me directly or via the company secretary. Thanks very much indeed. I'm not aware of any other business, if there is any. No, thank you very.
Can I just do one minute on inspections?
Of course you can.
If that's okay. Just quickly, it feels like inspection season at the moment. We had a housing inspection late last month. But at the moment in BCP Council, we've got 2 live inspections. So we've got the CQC inspections. We had our sort of set piece presentation earlier this week. So that's looking at our social care. So a real sort of opportunity for partnerships. So a quick thank you for David, who joined that presentation, and the inspections on site in early December, and it's the same for Dorset, as I understand. But we've also got simultaneously the CQC Ofsted inspection of special educational needs and SEND area-wide inspection. So that, so we were notified of that last week, and the inspectors are on site next week. So that is, it's not just the local authority, it's the area-wide. So once again, thank you for colleagues sort of around the table and beyond that sort of stepped up to take part in that. I think it's really important for us collectively to work together and to be seen to be working together on this. So thank you, but for awareness primarily.
Well, good luck. And thank you. And thank you very much for raising it. And these are system or partnership things. Thank you. Thanks very much indeed, Aidan. Any other businesses? No, thank you very much. Look, thanks for a good meeting, everyone. I think thanks again, Forbes, and to Claire for the patient story at the beginning, which was welcome in its own right in terms of the Leg Club, but actually really helped us later on to frame some of the discussion that we wanted to have on strategic commissioning intent. I thought that was really, really good. A couple of things just to highlight from the meeting. I won't go through every other item. We did emphasise the importance of the run rate on workforce, and that we take the right sort of activity into next year, and we need to keep an eye on that through committees and for board assurance here as well. I thought the point raised about an out of hospital estate strategy to link to what we want to do on neighbourhood health was very useful, and actually the discussion under the commissioning intentions about that being backed by capital and having capital plans in place and estate plans in order to deliver neighbourhood health was all really important. Thank you, Paul, for briefing us on J Hoots, and obviously it's good to see all the mitigation in place. On the performance report, thanks, Dean, for highlighting cancer 62 days and UEC. And I thought it was good, Kay, to ask about CYP, children and young people, slippage. And we also had a good discussion on no criteria to reside. I thought the commissioning intentions discussion was really good, not only around how do we turn that into substance, but some really interesting comments and insights around, for example, market shaping and things that we do together. And also very good to hear Alison and Chris about a joint finance group across all our partners, so that there isn't cost shunting or unintended consequences, or if we are having impact on each other, it's being done up front and in a mature way, in the way that you suggested, Catherine. Is there anything else from the meeting that anyone wanted to highlight? I hope that gives a fair summary of the diet of what we discussed. Anything I missed? Other than please say well done to staff. You know, I think all the comments from the board about the difficulty at the moment, particularly for ICB staff, is appreciated. Can we agree the exclusion of the public for part 2, please? In which case we're finishing 2 minutes early. You can have 32 minutes for lunch rather than half an hour. And I will see you at 1:30. Thank you very much.